So my objectives for today's talk are to just generally give an overview as to how patients get diagnosed with kidney cancer, what happens after they get diagnosed with kidney cancer, how we then as physicians will stage kidney cancer, how we offer treatments initially. Many patients are initially treated with surgery, and so we'll talk about those initial decisions for surgery, possibly talk about decisions against surgery up front, things like that. We'll talk about the curability of kidney cancer when it's found early with surgical management, and then we'll talk about what the future holds after you have surgery and have the diagnosis of kidney cancer. So when we diagnose kidney cancer, most often now it's found as an incidental tumor, and the medical community or medical establishment has decided to call that an incidentaloma, so that the majority of patients we find nowadays with kidney cancer are found when we do imaging for other causes. So often patients come in with abdominal pain or other ailments or illnesses, and they'll have an ultrasound or a CAT scan, and we'll find an incidental kidney tumor that is then discovered to be kidney cancer. So that's the majority of patients that we're finding today. The nice thing about that is that when we do find those, they're usually offered therapies that are curable at that point. So the nice thing about catching tumors like that early is they are curable. There is still, though, the rare patient that presents with what the medical community used to call the too late triad, which often meant that by the time they were diagnosed, it was something that was beyond the ability to cure surgically. So patients who presented with blood in the urine, if they had a palpable mass in their abdomen so you could feel a lump in the abdomen, or if they had pain in the flank, kind of like kidney stone type pain, those patients usually either represent more locally advanced disease or even disease that's spread beyond the kidney. In that case, surgically alone cannot cure the patient. And then there's 30% or one-third of patients who will present with disease that's spread outside of the kidney and elsewhere, what's so-called metastatic disease. And so in those patients, once again, surgery alone is something that is not curable, but surgery plus other treatment options certainly have been shown to have a great advancement in the last decade or so for treatment. So this just kind of represents what we find when we find kidney cancer. So almost 50% of them are localized, and that means that's something that's curable with surgery. A further 25% are what we call locally advanced, which means that it's beyond the kidney, but it's still within a surgical field that's removable, and those patients also potentially can be cured with surgery alone. And then that one-third of patients, unfortunately, that can't be cured with surgery alone. Surgery usually is part of the management for them, but they need other treatments besides surgery as well. Now, when kidney cancer spreads, where does it go to? Well, it can spread by two routes. It can spread through the blood, or called hematogenous. It can spread through the lymphatics, or lymph nodes, lymphatogenous. So it most often will be seen spread to the lung, lymph nodes, liver, bone, adrenal gland, which is that little gland sitting on top of the kidney that makes adrenaline, or to the other side, the other kidney, it can spread to occasionally as well, and then occasionally also to the brain and central nervous system. So when we see a patient who has kidney cancer, we want to make sure we rule out any spread to any other organs that would be possibly involved. And I alluded to this earlier, our diagnosis is made usually incidentally on some imaging that's done, usually on ultrasound or CT or MRI for other causes. About 40% of patients will be found that way. Once that we do find a mass that the radiologist will suspect is kidney cancer, what they'll do is send a letter to the family doctor saying that, and then they'll have to follow up with a referral, usually to a urologist, and then a urologist will do another test that tries to confirm what the diagnosis is. So if it's an ultrasound that was done initially, they'll usually get a CT scan or an MRI scan to see exactly what the nature of the tumor is, because those are a little bit better for tests for kidney cancer. And also, if surgery is part of the management, we want to know ahead of time the blood supply going to the kidney, the location of the tumor, and all these anatomic aspects that will allow us to deliver surgery better, because we know nowadays that surgical removal of kidney is only one option. We can also remove only a part of one kidney, and we need to know the anatomic blood flow to the kidney and things like that to make that decision. We also, when we see a patient with kidney cancer, the new diagnosis, we'll do what's called a metastatic workup. But we'll do some liver blood tests, we'll do some bone blood tests, we'll do a serum calcium level, physical examination, we'll feel for any lymph nodes, things like that. And that'll all comprise our metastatic workup for patients so that we can be quite reliable in saying that there's no cancer spread outside of the kidney if it is truly localized. Now, when we stage kidney cancer, we have stage 1 to 4, and obviously the early stages are usually smaller tumors that are localized. So stage 1 tumors are less than 7 centimeters. Stage 2 are greater than 7 centimeters, but they're still only in the kidney. They're not spreading outside of the kidney. Stage 3 are tumors that are in the kidney, but they're spreading along the blood flow that goes back to the heart from the kidney, and about 10% of tumors can do that. And then there's stage 4, where there's actually extension outside of the kidney, either to lymph nodes or to adjacent organs, liver and spleen that's kind of sit along top of the kidney, the adrenal gland that sits on top of the kidney. If there's cancer that directly moves into those areas, that would be a stage 4 type of kidney cancer. The blood vessel that drains the legs going back up to the heart, it also drains the kidneys of their blood flow. It's called the inferior vena cava. About 5 to 10% of patients will have involvement of that vein when we see them with their kidney cancer. And so what it can be is just a little bit of tumor that goes into the vein as the vein drains up towards the heart, and this is the heart, here are the kidneys. It can be a little more tumor that's growing up, so it's actually into the large vein, but it's not going above the breathing muscle, the diaphragm, and not into the heart. And it can be a little higher where it's up into the liver area. And then finally, it can actually, even in about 1% of patients, be right up into the right atrium of the heart. So we need to know this ahead of time because we need to plan our surgery appropriately. Obviously, these type of tumors need a much more aggressive approach that have much more complications from surgery, but they certainly are somebody that's curable. But we need to know ahead of time so we don't encounter this while we're operating, and we have a plan ahead of time, because in these more advanced patients, sometimes it involves us actually putting them on cardiopulmonary bypass, stopping their heart, opening up their heart, and then removing the tumor. And it's a pretty aggressive surgery, but it is curable in many of these patients. So despite the fact that these are locally advanced, they're still curable with surgery potentially. So I'm going to go through a few cases just to illustrate how I would offer options to patients. We'll start from kind of the most early type of disease that we see, the very small tumors. So this is an 82-year-old lady who comes into the office, and she has what they think is a gallstone attack. So her family doctor sends her for an abdominal ultrasound to look for gallstones. And they found gallstones, but they also found an incidental 1-centimeter tumor in the kidney. And they were sent off to me, and they said, well, how are we going to treat this? So this is just a diagram of something that we could see, just an animation. So this is the kidney, and it's kind of cut in half. This is the meat of the kidney here, where the blood will flow in, the urine will collect in the collecting system, and this will drain down to the bladder. And we see this one little mass right here. It's just sitting in that meat of the kidney called the cortex, 1 centimeter in size. So how would we offer treatment for this lady? Well, she's 82 years old. We know that these tumors are very small. They don't tend to grow very rapidly. And so when you're 82 years old, a best option probably would just be watchful waiting, or what we call active surveillance. We have many certain circumstances where we'd actually just watch a tumor rather than treat it, because in someone who's potentially old and wouldn't benefit from the treatment, they might have a lot of side effects or complications from treatment. It might not be the best to treat them. So in those patients who are not surgical candidates because they can't get an anesthetic, if they're too ill, they have really bad heart disease or other issues, we wouldn't offer them that. We'd watch this tumor. In older patients or ill patients who we don't think would benefit from the treatment, because these small cancers will take many years before they progress, if the patient just flat out says, I don't want surgery, that happens sometimes, and so we do have some patients refusing things, well, then we would watch that. And it's actually quite good for patients who have hereditary syndromes, and I'm sure you probably heard about that today, but about 5 to 10% of patients with kidney cancer actually have a genetic predisposition to getting kidney cancers that's inherited from the family. And in those patients, we know that they're at risk for multiple tumors in their kidneys and bilateral tumors in their kidneys. So we don't want to operate on everybody, because we run the high risk of ending up removing their kidneys, and we want to leave their kidneys in place for as long as possible. So we tend to watch these tumors to a specific size, and we have some criteria. Usually it's around 3 centimeters in size, and then we offer treatment. And at that point, when we do treatment, we actually don't only treat the one tumor, we treat all the tumors in the kidney that we can see. There's a lot of different surveillance studies in the literature, and we have a really large Canadian contingent that we actually published, coming out actually very soon, within the next month or two. Now, just the basic concepts of why active surveillance is a reasonable treatment for some patients. Well, this diagram here with these blocks that are stacked, that would just be a kidney. This lightning bolt would be something that causes a mutation in one of these blocks, which is a kidney cell, and that cell is no longer normal. That cell is a cancer cell. Over time, you get that cell to grow. But this time from one cell to many cells, so that we can see it of 1 centimeter, is many years actually. So it's not something that usually happens really rapidly. And then finally, when you have a tumor that you can actually see, so say something that's 1 centimeter on a CAT scan, by the time it gets really large with more mutations and actually poses a threat to somebody, it has to have a lot of mutations, it becomes very kind of aggressive, that's another number of years. So if someone who's older, we don't expect to do well with treatment, or is not going to live long enough to benefit, at this point we would just watch this. And they very rarely will progress to this point, as it takes a number of years to get to that point. So that's the basic concept of why we think surveillance for very small tumors is safe. Also in hereditary patients, we know that tumors won't spread until they get to be a certain volume, something like 3 centimeters, and in that case we can wait potentially years between surgeries for them by watching tumors slowly grow. And when we look at growth rates, the growth rates are actually pretty slow. This is some data that we published in Winnipeg looking at the growth rates of tumors. And so small tumors here would grow very fractionally over years, so 3 millimeters a year in these smaller tumors. But once you get over our size cutoff, 3 centimeters, then the growth rate becomes more significant, just almost 2 centimeters a year. So at this point, we can watch patients for a number of years. At this point, though, they start growing a little more rapidly, and that's when we usually offer treatment for them once they get to be about 3 centimeters in size. There's a second case that we have. A 62-year-old gentleman has a smoking history. He's a high blood pressure, diabetic. So he has some potential risks to his kidneys based on his comorbidities. His high blood pressure can cause damage to the kidneys. Diabetes can cause damage to the kidneys. So those are things that are important that we talk about when we see them in the office. He had some vague abdominal discomfort. He had an incidental finding on an imaging study with a small tumor, 3 centimeters, and that was confirmed on CAT scan after it was seen on ultrasound. So how do we treat that gentleman? So his tumor now is 3 centimeters, and he's 20 years younger than the last patient. Well, he still could potentially have a time of active surveillance if it wasn't going to fit into his schedule. In Winnipeg, we have a lot of snowbirds, and they often like to go down to the U.S. for months on end. So if he wanted to defer treatment for a time, that's reasonable. We'd say, well, we'll see you when you get back from your holiday, and we'll talk about things. If the patient, if he was quite unhealthy, so if he had terrible heart disease and he was expected to die from a heart attack in the near future, we wouldn't probably offer any treatment for him other than surveillance. But if it's possible, the treatment that we would choose at this point would be to remove only the portion of the kidney that has a tumor in it, or to do some ablative therapy which would get rid of that tumor but leave the rest of the kidney behind. Very rarely in this context with a small tumor would we offer a complete nephrectomy removing the whole kidney. And the type of ablative therapies we have available, and I know in Calgary they're actually doing cryotherapy. A really competent doctor named Dr. Donnelly has actually started cryotherapy in Canada, one of the kind of preeminent cryotherapists in Canada, so he does offer that here. So how would partial nephrectomy work? Well, here's a diagram. So what we would do is, this is that small tumor in the kidney. So 90% of the kidney is entirely normal, and that small area has a tumor in it. What we would do is we would carve that tumor off of the kidney. We would close any collecting system defects here, which is at number 2 there, and then we would sew the kidney pieces together, and that would leave you with 95% of a normal functioning kidney, and we would be able to eradicate that tumor from the kidney at the time of our surgery. And that would be something that's potentially curative by doing that. So the nice thing about that is, if down the road you depended on that kidney because you have blood pressure issues or have borderline kidney disease and you needed to save that kidney, we wouldn't be removing that kidney, just that part of the kidney that has the cancer in it. We've been seeing in the past, unfortunately, that this practice of doing a partial nephrectomy had been dropping, and taking out kidneys had been getting higher. But that now is actually changing, now that people realize that this is a very safe treatment that gives as good of a cancer cure as taking out the entire kidney. The other thing that I just mentioned was the cryoablation. There's also something called radiofrequency ablation. I do both of these. You can put little probes into these tumors and you can freeze them or burn them, and this basically just diagrammatically shows that. And nice thing about this is, again, it saves the majority of the kidney from damage. It can eradicate the cancer so it's gone, and it's a more minimally invasive treatment. Both the partial nephrectomy and these ablative technologies can be done either with laparoscopic techniques, the little keyhole surgery, or they can be done by just using image guidance called percutaneous treatment. So the day of having to have a gigantic incision for these kind of things is now past, which is quite nice. So for small tumors, we'd say the laparoscopic, partial nephrectomy, or ablative technologies probably is the best treatment that you can get. Sometimes, though rarely in small tumors, you still need an open surgery because the tumor might be really, really deep in the center and require a lot of reconstruction of that kidney. So you end up having 2 separate pieces of a kidney and you have to put them back together. That kind of surgery should not be done laparoscopically. That would be done through an open approach. But by far the majority of these tumors can be done that way. It's very important to do that if you have a person with a solitary kidney, so they've had a kidney removed in the past and you're working only with one kidney to begin with. That would be very imperative to do what's called a partial nephrectomy or an ablative approach. And for these hereditary syndromes where people are at risk for tumors on both sides, you want to leave them with as much kidney as possible. If the tumor is larger than 4 centimeters but less than 7, which is the kind of a T1B lesion, if you can do a partial nephrectomy, try and do that. We try to do that if it's possible, and we know that it's still safe to do despite the fact that the tumor is a little bit larger. If it's not possible, though, then in some cases a full nephrectomy or what's called a radical nephrectomy is done for treatment if the tumor is between 4 and 7 centimeters. Just one more case here about a young gentleman, 55 years old, current smoker. He had some blood in the urine, painless blood for about 2 weeks. It stopped spontaneously. He reported that to his family doctor. He had an ultrasound done. It showed a large kidney tumor, about 14 centimeters in size, from his left kidney, and was sent to me to see how to treat him. So for him, with a tumor that's kind of replacing the majority of his kidney, there's a small cap of kidney here, but that would not be worth preserving. We would have to remove the kidney, and so this would be a so-called radical nephrectomy, and they call it radical because it involves removing the kidney, removing all the fat around the kidney, and occasionally we even remove the adrenal gland if the tumor is sitting right on the adrenal gland or the adrenal gland has an abnormality to it. Now, those treatments can be done laparoscopic and open, and by far the majority of them now are done laparoscopic, which gives a benefit for patients because it's, once again, a keyhole type surgery rather than a big open approach. So I alluded to the benefits of the laparoscopic approach where it's possible. Well, a shorter hospital stay has been demonstrated, so only a couple of days in hospital rather than a week to 10 days or longer. Much less postoperative pain. You get back on a diet quite soon after the procedure, so the night of the surgery you could probably start having a diet at that point. Your work, much shorter period of time, so 2 weeks rather than 6 weeks to 3 months. Very small incisions, so for some patients it's a cosmetic appeal. One of the younger patients I've ever operated on was a 17-year-old model, and she had a papillary kidney cancer, and she definitely did not want to have the incisions. So we did everything with the little scars and the little laparoscopic approach, and she would still be able to do her bikini modeling and things like that. So that was important for her. And we know that also if there's the reason that you had the kidney out so that you could get prepared to have other systemic therapies, laparoscopic surgery is better because you can get onto your systemic therapy faster so that you have less downtime and you can get onto further treatments if you need. So that's also a very important point. And here's a case I just threw in. It was a last-minute case. I actually operated on him yesterday. It was a 31-year-old gentleman. He had right leg swelling for a couple of weeks, and an ultrasound showed that he had a blood clot in his leg. And it turns out the blood clot was because he had a big cancer in his kidney that was growing up into that vein that drained the blood to his heart, and he had basically clot all the way down to his toes from his kidney. So he came in to see us, and we looked at him. We got an MRI. It showed that he had that extension of that disease going out of the kidney. So basically what it showed was there was a large tumor here. It was growing along the veins and going up through that vein that goes up to the diaphragm. Now his was not quite up to the diaphragm, but it was close. So he did well. I was able to fly out after I finished operating on him, so it was actually quite good. And we would hope that that would cure him as well. So this is about 5 to 10% of all kidney cancers that are stage 3. These surgeries cannot be done laparoscopically just because of the complexity of the surgery. So this has to be through a big, usually a very large incision that's a little frowny face incision below the chest, or an up and down incision just in the midline. Occasionally, if it goes right into the heart, it requires bypass surgery with that, so you have to actually put people on cardiac bypass. Even with this kind of locally aggressive disease, though, surgery can cure about 50% of people. So it's something to always keep in our mind that some older urologists might say these kind of things are more incurable, but we can realize nowadays that often when there's no other disease outside of this area, surgery alone can cure patients. So now that the patients have seen us and we've decided what type of surgery they would or wouldn't need, what happens next? Well, unlike some other tumor sites like colon cancer and breast cancer, often after surgery you get treatments like chemotherapy and radiation. But with kidney cancer, we don't really have very good treatments after surgery where there's no disease that's visible to treat. So we know that conventional chemotherapy doesn't really work well for kidney cancer. We know radiation itself is not a very good and very active thing for kidney cancer except if it's spread to bone. So we don't have what's called adjuvant treatments, which means after surgery when there's no disease but you're at risk for getting disease back. So at this point, nothing other than just follow-up or potentially being put into a clinical trial is what's done after your surgery. We do have something called a cytoreductive nephrectomy, and that I'll just talk about it briefly, is that when someone presents with kidney cancer that's spread outside of the kidney, that's not curable by surgery alone, we realize that if you take the primary tumor out the kidney with the cancer, you can actually have an improvement in overall survival with that. So they call that cytoreductive because we're removing 90 to 95% of all the tumor cells in the body with surgery, and then the treatments you get afterwards only have to work on a smaller volume of cancer. And they've shown that that actually has been a survival benefit to patients. So when it's possible, someone should try and take out a kidney even in the face of some disease that's outside of the kidney because there is a survival benefit noted from that. There has been some adjuvant trials, though, that were out. We had one that closed in September of last year called REC2, which Canada did really well accruing patients to. We, I think, had about 10% of all the worldwide patients came from Canada. And there's a few other smaller trials out now that are open. I think one was talked about this morning. There's also a few investigator-initiated ones in some universities across Canada that have adjuvant trials that are opening or open. So that's certainly something that if you see your doctor and you say, well, I've had my kidney cancer removed, are there any clinical trials for me? That's something that would be a good question to ask. Now, if there's no spread outside of the surgically removed cancer, so even if it's a locally aggressive one, but we get all the cancer removed surgically, what happens? Well, our standard follow-up is very standardized, and I saw actually there's a reprint of an article here that had a consensus statement on what we do for standard follow-up after. So when it's an early stage, so less than 7 centimeters, we do annual blood tests, which are liver tests, bone tests, things like that, kidney tests. We do a physical exam, we do a chest x-ray, and at years 2 and year 5, we'll do a CT along with those as well, just to make sure that there's no local recurrence. So if we did a partial nephrectomy, make sure there's no new tumors developing in that kidney, and also make sure there's no spread of that tumor. Stage 2 disease, we will follow a little more closely because it's a bigger tumor, so it's over 7 centimeters in size. 6-month blood tests, physical exam, chest x-ray, and CT scans at years 1, year 3, and year 5, because we do more CTs because you're at higher risk potentially of having cancer return. And then stage 3 and 4, which are the more aggressive cancers, we want to follow them even more aggressively because our goal really is to catch any recurrent disease early so that we can either sometimes surgically remove it and cure somebody. So even if someone has a tumor spread to the lung perhaps, sometimes we'll remove the lung and that would be curable potentially. Or if there's disease, clinical trials out there for this kind of disease, then we want to get the access to that early and make sure we find the recurrence early so we can get them into clinical trials. So for the more aggressive stages, we do all these tests that we mentioned, but we do CTs also at, all the tests are done at 6 months for 2 years, including the CT, so it's not done on an annual kind of basis like these ones. And then we also do it all at year 3 and year 5 again, because we're more concerned that the cancer will come back and we want to make sure we catch it early enough so we can either get you into a clinical trial or try and manage it surgically if possible. So these are just some survival statistics from some older data. Survival is improving dramatically, which is great to see. But once again, it just kind of says it's hard to improve on this kind of success where our 5 and 10-year survival is over 90% when we're treating patients that have lower stage disease. So that's actually really good. The thing that we actually have to get some work done on is this survival when people have spread outside of the kidney. Fortunately, we had major advancements in the last decade with kidney cancer treatment, and we're seeing that our survival rates are improving dramatically because of the treatments that we're rendering. So that it's actually a very good thing. When I started my practice in the early 2000s, we didn't really have a lot of the medications we have for kidney cancer that we have now. So it's a much more optimistic outcome now for patients. So just in conclusion, the role of the surgeon is paramount in the management of patients because often they're making the initial decisions as to what kind of treatment is rendered and where you go for clinical trials or medical oncology follow-up, etc. Some observational approaches are reasonable, like I mentioned, with low risk of having issue from that. The role of surgery in all stages of disease, so when disease is localized, obviously, but even in settings where the disease is more locally advanced or even when it's spread outside of the kidney, surgery to remove the kidney can be beneficial. The laparoscopic keyhole surgery is growing in popularity, especially for stage 1 and stage 2 disease, and I'd go as far to say is if you're seeing somebody about kidney cancer and they're not offering that to you, a second opinion probably should be given. Partial nephrectomy or ablative technologies for small tumors is really revolutionizing treatment for these small tumors and making it much better for patients, preserving their kidney function for any further treatments that they might need for cancer if they do need it. And cures with surgery is possible even when we have really locally advanced disease. So it's certainly one of the standout needs for patients with kidney cancer. Thank you.